Hello, everyone, and welcome to the third webinar of the EPUS. It's good to see all the attendees again. This is going to be our last webinar of Ramadan, and hope you enjoy it. We have a very special assortment of guests tonight. I'm going to start by introducing our guests. Dr. Parsa. Dr. Parsa is a very international pediatric ophthalmologist. He graduated from New York, and after his residency, he took a postdoctoral fellowship in the neuro-ophthalmology in California with Dr. Hoyt. And then a pediatric ophthalmologist STRABISMUS fellowship in Baltimore with Dr. Guyton and the exceptional team there. It's actually rare to find someone with such combined experience. Not only is he double trained in neuro-ophthalmology and pediatric ophthalmology, but he has a vast international clinical research and research experience. He practiced in Johns Hopkins, University of Wisconsin, in the Sorbonne University in Paris, and the Université Libre de Bruxelles in Belgium. He has a very respected list of publications. He is a truly international pediatric ophthalmologist and neuro-ophthalmologist. We're very lucky to have him with us here. Dr. Parsa. And Dr. Farouk Orgey. Very few people in the field do not know Dr. Orgey. His CV is very rich. It takes a very long time to go through his CV. He spent a long time in Indianapolis, did residency, fellowship there, and we got to be friends from meeting on those fellowship meetings there. He moved then to Ohio. He became very prolific in his field. He's one of the most active pediatric ophthalmologists I've ever seen. Currently practicing in Rainbow Babies and Children's Hospital, University Hospital Eye Institute, Case Western University Reserve, Case Western Reserve University. Besides being director at large in the APUS, Vice President of the IPOSC, Medical Director of Quality in the UH Eye Institute, Fellowship Program Director. I can go on for a very long time. In spite of all this, Farouk, if you may allow me to call him so, is a very humble and down-to-earth person. Very friendly. You always feel comfortable around him. We're very happy to have him here. Next is my colleague and my professor, Dr. Nihal Shakhankliri. We call her the wizard of pediatric cataract surgery. For those of you who do not know her, she's devoted to pediatric cataract. That's what she does all her life. And everyone enjoys watching her surgeries. Dr. Ibrahim Al-Adawi, my professor as well, a talented strabismus surgeon. He's always been doing those meetings in his hometown in Mansoura. When I was young, when I started my strabismus, learning about strabismus, he was one of those who taught me in the very, very beginning. Dr. Muhammad Farid, my co-moderator today from Banha University. Again, a very talented pediatric ophthalmologist. We enjoyed working together on preparing this webinar. We hope you like it. So without further ado, and myself, of course, my name is Amr Al-Kamshushi from Alexander University. Without further ado, we're going to move to our presentation. For those of you who haven't joined these webinars before, you can use the chat buttons, as you can see, or you can use Q&A if you have any questions or answers and we're going to answer these questions as we go through. We're going to go to the first case. Our first case is going to be nystagmus. As you can see here, look at this child. This child has been born with his nystagmus. This is infantile nystagmus. He has a preferred head posture. His preferred abnormal head posture is a left face turn. This is where the nystagmus dampens. In the primary position, the nystagmus increases a bit. When he puts his head to the left, the amplitude and frequency of nystagmus increases. So he prefers to put his head towards, he puts his head towards the left, the nystagmus dampens, and he puts his eye in right gaze. And then we would ask the audience to share with us in a quick poll. I'm going to launch the poll now. How would you treat a horizontal abnormal head posture of 30 degrees? Would you do a Kestenbaum-Anderson procedure, an Anderson only, Kestenbaum-Anderson, Kestenbaum only, augmented Anderson, none of the above? There's always variation in decisions in this kind of cases. We'll give it a few more seconds. As you can see, most people voted for Kestenbaum-Anderson procedure. It seems like the most popular procedure. However, there is a variation of opinion. let's see. First, I would direct the question to Dr. Parsa. If you get a case of horizontal abnormal head posture, which technique would you prefer of these and why?
Basically, I would do what we're calling the Kestenbaum-Anderson procedure, recessions with resections, because you have longer lasting results when you do an R&R than especially a resection, which tends to undo itself. And recessions, which would give you some weakness by recessing a muscle too much, you would have to get weakness in its action. What I would emphasize in a case like this, though, where we saw the child with the head turn and we saw the less nystagmus when it was looking to the right, was to be sure how much to move the muscles. That may not be the null point that we're seeing. The null point people usually think of as being where there's the least amount of nystagmus, but the true definition of a null point is the point beyond which the nystagmus changes its direction. So even though looking all the way to the right, we see the nystagmus is at its minimum, it might have been that looking further right, it would still be less, and further right if we could, but it's blocked by the orbits, we would get the reversal of nystagmus. So if we only operate for what the head turn is, we'll get an undercorrection usually. So we really have to put prisms in front of this child's head and note how many degrees away does it take of looking until we get a reversal of the direction of the nystagmus. That's the key point that I see leads to many undercorrections. So
that's interesting. So you always measure these kids with the prisms, not only the abnormal head posture.
Exactly, because the null point by definition is the minimum of nystagmus beyond which there's a reversal of the direction of the nystagmus. That part is sometimes left out in definitions, and it was Craig Hoyt who used to emphasize that to me as being the #1 reason why we get undercorrections when we're doing, say, a Kestenbaum-Anderson procedure, is that we're not examining for the reversal of the nystagmus, and we're just doing the head turn, which is an insufficient measure of the degree of strabismus surgery we'll need.
Interesting. Dr. El-Adawi, do you agree with this? Would you do a Kestenbaum-Anderson for a nystagmus? Or would
yes.
you combine that with something else?
Yes, Dr. Amr. I used to do a Kestenbaum-Anderson procedure, recession, resection, because recession only or resection only cannot correct such degree. Recession only, I reserve it for the vertical nystagmus with the chin elevation or depression. Can give a good result, but in horizontal nystagmus, usually I use Kestenbaum-Anderson recession resection.
Did you ever experience a case of strabismus after Kestenbaum-Anderson? It's unlikely to happen.
Rarely I met a case of strabismus following nystagmus surgery. And in such a case, I manage the case according to the degree.
So it's not a threat to be worried about.
Well, I would say, do you hear me?
Yes, we do. Yes, go ahead, Dr. Parsa.
I do worry about it in the sense that it's always possible to induce a strabismus in someone who hasn't had it. So I try to defer surgery if possible till after the age of strabismic amblyopia, until they're 8 or 9 years old, so that if I do induce a strabismus, they'll be diplopic and not develop a suppression scotoma, and then we can reoperate.
That's interesting. I mean, again, you delay the age of Kestenbaum-Anderson surgery to 8 to 9. Dr. Adawi, would you agree with this? Do you operate at what age do you operate on nystagmus cases?
Usually, I operate at 8 years. I mean, from 6 to 8 years, at the school or preschool age.
Okay, you do preschool or school age?
6 to 8.
Okay. Well, we started by the horizontal. We're going to move to something more difficult. As you can see, here we have some studies that show different treatment options, large recessions, different numbers for recessions, augmented Anderson procedures. It's not only the Kestenbaum-Anderson, other people have different opinions, but see, our panelists agree on the Kestenbaum-Anderson. Now, this is the second case. This is a normal head posture in nystagmus as well. However, it's more tricky because preferred abnormal head posture is a chin up. So this child has his null point in down gaze. Doing this surgery would cause challenges because you have to weaken the down gaze, you have to interrupt the down gaze. So it's not as easy as doing on the horizontals. We're going to go through a quick poll as well, and then hear the opinion of our panelists. Let's see what everyone thinks of this one. How would you treat this chin up of 25 degrees? Inferior rectus recessions, superior rectus resections, or combine them, do an inferior rectus and the superior rectus, or inferior rectus recessions and superior oblique thenectomies aiming at weakening all the elevators, or a horizontal muscle upshift. I expect to find more variations in answers in this one because there is less consensus on how to treat vertical abnormal head posture. And it's a good thing we're not going to discuss head tilts with nystagmus because that's going to get way too complicated for tonight. So let's see our results. We seem to have variation in results. However, everyone agrees on everyone is doing an inferior rectus recession, and some are combining it with superior rectus resections. Now, we're going to move to Dr. Orge. What do you think of the vertical abnormal head posture surgery options? The surgical numbers, that's a question. I know you have some experience in that for the vertical and the horizontal. And at this stage, I'm going to stop sharing my slides in case you want to share a slide to explain your answer.
I would love to. Let me make sure that I'm.
And the age of surgery as well. Do you agree that you do the surgery at the age of 8 to 9 years, or do you do it early, like 5 to 6 years?
I actually do the nystagmus surgery is a little bit earlier than what was mentioned. And just to kind of, before I show my preferred table on the vertical, I have to say that the variations that you've seen, they all kind of work in different scenarios. For example, if the child had a infantile esotropia, then developed a null point, which does happen, and you've done a BMR in a maximum fashion, what do? That's a very different problem than you've never had any strabismus surgery per se, and how to react on that. And the other thing is, when you look at the historically, how it came up on the horizontal, then it translated into the vertical. On to do the procedures for the null point nystagmus is, again, we all know about Anderson and Kestenbaum, very differently came up with the ideas of nystagmus surgery at the same year. That's why we kind of combined their names in that. Many moons later, late Marshall Parks came up with this 8-5-6-7 rule that actually made sense to him. And I think the world adapted with that, and it was mildly modified by Dr. van Noorden as well. The variations do work, and actually a lot of studies do show that single muscles do work in certain instances, but you have to really augment the amounts. I can tell you that for the horizontal in particular, that the four muscle large recessions are not as useful as we thought it would be, and does tend to cause the big or some exotropia in particular, so strabismus. And I always thought that it was a little bit confusing. The 8-5, which muscle you do 8, which muscle you do 5, and 6-7. And what if we had a strabismus, how do you incorporate in that? I actually remember reading different papers about it and talking with Dr. Deloso. He actually mentioned, he's a PhD that spent his life in nystagmus. He mentioned that, well, maybe we should do all the muscles in the same numbers. And this discussion actually led us starting doing that. So for the horizontal, we've been actually doing these equal muscle surgeries. And it just sounds very bizarre, but it actually does work. I have about 50, 60 patients so far since 2009, I think. And so you do, for example, for the 30 degree, I would do a 6.5, 6.5, 6.5, and 6.5. It's just amazingly, it does work. Coming to there's the practicality, and there's this technical, if you really want to be on top of things, I think you need to really measure the nystagmus with a nystagmometer. And not many places do have that, and it's just not a common thing. So then the practicality goes forward. So the visual acuity guides in that, and actually checking the visual acuity in different gazes can be a guide as well for people. So back to the vertical. So my algorithm actually is not very different from what Dr. Hertel, Rich Hertel defined. And for the vertical, there are 3 options, as you mentioned. For the bilateral superior rectus recession with the inferior oblique, actually, I'm going to go to the second one because that's the portion that you were asking for, the chin up. 3 options, again, the bilateral superior oblique tenectomy and the inferior rectus recession. And then bilateral inferior recession and bilateral rectus recession, although they all do work, what works best in my hands and what I've seen, what I've talked with Dr. Hertel is the first option. And how do you grade that? And how do you do that? Is just, I think it's just and if you're comfortable with the tenectomy going to the superior oblique, I think is the guiding force for
complications that
you always worry about these things. And again, scar tissue and many things, just you do worry. But similar to the Kestenbaum or Anderson-Kestenbaum procedures that you do, we actually don't really see that. And especially with the chin, not maybe up, but the chin down position is probably a very devastating position, but because they can't even look through the glasses. So that affects the vision in so many different ways. And they tend to be fairly comfortable with that, and they compensate with mild maybe turns. But with this numbers that I'm kind of showing in the slide, I have not seen any restriction, personally at least.
Dr. Ladawi, about the indications of surgery, I mean, when you have a patient of nystagmus with abnormal head posture, when should we operate him? I mean, if he's complaining, if he's cosmetically complaining, is there a certain degree of abnormal head posture? Sometimes we see this head posture and the patient is not really complaining of it. When would you decide to do surgery?
Mainly the amount or the degree of abnormal head posture. If the child go to the school with 30 degree of face turn to the right or to the left, this is disability for the child in the school. So the main indication is the amount of abnormal head posture.
Okay, so depending on the degree of the abnormal head posture. Okay. Now we go back to our presentation, and now we push up things a little bit up. We're going to see a case. This patient, as you can see, she has a nystagmus, again infantile onset nystagmus, but this time when you put a base out prism, the nystagmus dampens. So when she attempts to do an adduction convergence, the nystagmus dampens. We don't see that. There's something called artificial divergence surgery. It's mentioned in literature, a little bit older literature, but it does exist. I would direct a question now to Dr. Parsa and his vast experience in nystagmus and nystagmus surgery. What do you think of these cases where the prism improves the nystagmus? What do you think about the artificial divergence? Would you combine it with Kestenbaum-Anderson procedure? Would you do it on its own, the surgical numbers? What would you do?
Well, this patient didn't have any strabismus, so I wouldn't combine it with any other procedure other than if one wanted to do surgery, to do artificial divergence surgery. As a general rule, what I'll say is I'd always do a cycloplegic refraction and put them in their full correction before I decide on doing anything. Once I do that and see what their nystagmus may be, I'll repeat that prism test, see if we have similar results or not. If it's obviously what's happening is we're using the near reflex triad, convergence, meiosis, and accommodation that dampens the nystagmus here. One could get a similar result, presumably by putting over minus lenses in front of this girl's eyes. She would have to accommodate more, and that would give a similar effect on dampening the nystagmus. If she's very hyperopic at this young age, which is likely she has some hyperopia, and one does the divergence surgery on her, it may work on dampening the nystagmus, but as she gets older and she loses her hyperopia, she won't be able to elicit that same near reflex without blurring her vision. So you run the risk of having a short-term positive result by inducing a divergence for which she has to correct, but then inducing later on a blur, because after her eyes grow and she no longer is so hyperopic, she would get blurred vision from induced myopia. So I think the first thing is to look at what the refraction is in that child, cycloplegic refraction. Perhaps play around with that to see if you can dampen the nystagmus using just plain glasses, regular glasses, for example, over-minus lenses. And then if you find that's not sufficient, or you're afraid of inducing more myopia, because that's possible with putting over-minus lenses, then putting base-out prism. I would hesitate to do the artificial divergence surgery, because I think it's intimately linked to the amount of accommodation that's also elicited, and that will change with time. It's invoking the near reflex that dampens the nystagmus, and the near reflex has three components. It's not just the convergence, it's the accommodation too.
Dr. Parsa, for our audience who are not familiar with the procedure, can you please go over what's artificial divergence procedure and when to do it? I mean, what's the case criteria where you do artificial divergence, and what is artificial divergence? In a minute, can you wrap it up for us?
Well, I presume it's just recessing the medial rectus muscles so that the eyes diverge, they're more exophoric, and then by eliciting the near reflex, convergence and accommodation, the patient will be seeing straight but with less nystagmus.
And when do you do it? When do you do it? When do you decide you're going to do it?
As I was saying, I would try to stay away with it in the pediatric group, because they tend to lose their hyperopia as the axial length grows in eyes. And so a surgery that's initially successful at eliciting not just convergence, but accommodation simultaneously, hyperopic, they can tolerate it very well. But once as they grow older, are no longer hyperopic, it will induce blurred vision. And then in the older patients, if you do that, it can work, but then as they get presbyopic, they have to elicit more and more effort to have the eyes straight. You might even get some sort of over convergence at times. I haven't run into that, but that's what you would think would happen. So the bottom line is I don't really plan on these surgeries so much. Okay, so I try to use glasses, prisms, and defer on it. And I haven't followed many long enough to know what happens later to them when they go off to somebody else's practice.
So you're not a very big fan of artificial divergence. Okay, Dr. Orge, and quickly we go. Well, I want your quick opinion over like the over-minus glasses, putting prisms in the glasses, and over corrections. What do you think of each of these, especially the over-minus in glasses and putting prisms in glasses for cases of nystagmus? How often do you do that?
So it actually, what you're referring to is probably more to do with this type of case, in the sense that the convergent null nystagmus, which is actually very classical, that you put 7 base-out prisms altogether, 14. That's typical that, again, without any underlying strabismus, that's the key, because you may be getting into the latent manifest nystagmus. So if I have a deviation and you're correcting that deviation, then you may actually kind of see the nystagmus. That's one thing. But if there's no strabismus, as Dr. Parsa mentioned, and you had elucidated in this, actually with the convergence null, and if it is, and that's how you do, you put 7 base out in front of both eyes, and if it dampens, you know that's the case. If you're going to give the prisms, because they do work, to the patient, you have to over-minus, as Dr. Parsa was mentioning, just because they tend to, and how much do you over-minus? It's about -2. It's not a typical thing that this formula doesn't work with any other nystagmus. This is mainly for this, at least in my experience and what I've done and seen in my clinic. But for these patients, they actually do fairly well. Now, if they all work and they're happy, but they want to get rid of the glasses, again, the procedure is as Dr. Parsa mentioned. I tend to do 3 millimeters of recession in both medial recti. That actually causes this, and it does help. But again, -2 sometimes is required after this. It's not atypical at all.
So you do artificial divergence procedure? I do.
The indication is extremely rare, though. I'm in a vicinity that actually, because of the Deloso and everybody else so we see nystagmus quite a bit for referral. Even in that scenario, I can tell you the indication came up maybe 3 times in the last 5 years. It's actually fairly kind of rare in my instance, at least.
Dr. Mohammed Farid, do we have any questions from the audience or any comments?
Up to the moment, we don't have questions regarding the nystagmus cases.
Okay, we have one question. It says, I think directed to Dr. Parsa, how do you measure it by the prisms? Can you give us a little note of how to measure it how to use the prism to measure the abnormal head posture? How do you use the prism in order to?
You just put prisms in front of both eyes. As you see, and as you put more and more prisms, their head posture normalizes. You try to reduce that posture with the prisms, and then you see the eyes as they become straighter. For example, that one that was all in right gaze, as the eyes become straighter, what you do, and you can see more sclera, you can ask the patient with the prisms in front to look further that way and see if the nystagmus further reduces, and then to see when does the nystagmus reverse its direction. And then that's what you know is the true null point. And you put more prisms until you have the null point right in front. And you base the strabismus, amount of strabismus surgery based on what the prisms tell you. That's how David Guyton, measure. It's not the 5, 6, 7, 8 rule that Parks talks about. It's how much strabismus surgery would you do to correct what the prisms are telling you is necessary to get the null point, the true null point, where if you go to one side, the nystagmus beats this way of it, and if you go to the other side of the minima, the nystagmus beats in the other direction. And that I can't overemphasize enough, which is really the #1 cause why we get undercorrections, is not looking for that reversal of the direction of the nystagmus about the null point. And the prisms tell you how much to operate on. So you just go to the tables for your strabismus surgery and say, okay, I'm going to operate on that much. Now, that's one way of doing it, and that's how I try it.
I have a question, Dr. Am, from one of the attendants.
Go ahead.
It's for Dr. Orgay. They asked if a significant head posture in the age of 1 year isn't waiting till the age of 8 years can cause significant torticollis?
That's a good point, and that's what's always brought up. But the fact of the matter is, for even a 30-degree turn, you will have the torticollis. Obviously, that's what we're talking about, 30. But in terms of getting cervical problems, that won't happen for at least 2, if not 3 decades. So even someone with a large head turn, they're not going to really complain about neck problems until they're in their late 20s or in their 30s. So I emphasize that to the residents to say, we're not going to wait that long, obviously, but it gives us plenty of time to wait till, say, they're out of the strabismic amblyopic age range. And so we don't need to worry about this. It's a true fact that they'll get cervical neck issues, but we have to emphasize what is the timeline, and it's not in preschool age where that will happen. I mean, they're so flexible, and they don't get.
I have to say,
you agree?
Different approach to that. The reason is, at least my training and how I kind of look at it is, and I try to kind of empathize. I 100% agree with many things that Dr. Parsa and Dr. Ibrahim had mentioned, but I tend to get the approach on, if you know that it's consistent and you're getting the same amount all the time, because I think the most important thing to kind of rule out or not to miss is the periodic alternating nystagmus. Because if you've done an Anderson-Kestenbaum for a periodic alternating nystagmus, then you're in really bad shape because it changes. And if you didn't give enough time for that change to happen, then you can actually do a wrong surgery for the wrong indication. In my cases, though, I have to say that any anomalous head posture is something that you can help with them with. And actually, even I tell the families, and it's just not an easy thing to kind of look at the world like this, and they can't maintain it simply because it's just tiring. And we tend to kind of, you can see by the visual acuity how much of these the patients have been affected by if they don't assume the head posture. And I actually tell the parents, turn your head and start walking and see how that feels. And in my case, I prefer to do them sooner. Now, my indication is it's not a particular age, but the consistency. They have to prove to me, or I have to see it at least in 3 different times. And I look at them actually for about 10 minutes, that they are showing the exact same amount. And actually, Prism method is fantastic. I actually use, because the kids sometimes don't allow you to do that, I use a protractor. I show a video from a distance, and actually I'm looking from the top at the patient, and I use a protractor and use the nose as the direction on how many angles, and that's how I practically do it. And that has been fairly helpful, and actually I do it much earlier, even less than 2 years and even less than 1 year in occasions, depending on the consistency. I don't remember if any patient that I wished I didn't do it. I think that's the key part. I haven't seen any problems that I had reversed, and all the procedures that we talked about, you can actually reverse it, and depending on the amount and how the surgery is done. So I take a different approach in that sense.
Right. How do you avoid inducing a microstrabismus?
How do I look at the microstrabismus?
How do you avoid inducing a microstrabismus? If a child has no strabismus but just has a head position, and I understand empathizing, but when I ask an adult to take a head position that a child is taking, it's 2 different animals we're dealing with. It's much more tiring for the adult, for the child, than for the child. They don't complain of it. But unless in its extreme head position, and there are some cases where the child has an extreme chin up position and is arching backwards to walk, and then one would obviously operate earlier. But unless it's something that is really causing an immediate problem, I'm afraid of inducing a microstrabismus on someone who had perfect stereopsis. And the earlier one operates, the easier it is to do that and not even be aware of it. So that's why I would rather wait until all things being given equal, that the child can tolerate it. I'd like to wait till they're safely out of the strabismic amblyopia age range and then operate.
I think it's easy to decipher less than 7, 8 in much younger patients on microstrabismus. I really do think that's plausible. Obviously, I worry about under overcorrection in any strabismus surgery that I do, including the nystagmus null point. But I have to say, my series, and we actually recently looked at it, maybe I was lucky, maybe, and it's just not only me, because I always have fellows and residents around, and it's difficult to hide stuff in that sense. And actually, we have the advantage of used to, not now, but used to have Delosa actually doing the nystagmus recordings on top of that for our patients. I have to say, I haven't seen, so the microstrabismus for the amounts that we're doing is not a common thing. I think when you're doing drastic surgeries like big recessions in all 4 muscles, that's the time that people tend to see. I don't think it's common. At least that has been my observation. How often do you think that is gone? Because obviously that is a fear, and that has to be something that we all have to be careful in. But there must be certain trials that you've seen that it actually induces this. I haven't come across with that.
I think that whenever we operate on a child who doesn't have strabismus, okay, if they already have strabismus and nystagmus, then there's no proof it. But if I know they don't have a strabismus and they just have nystagmus, aren't any trouble. I'd like to see what the stereopsis results are of those children when they're adults, to see what happens. So
I would have to step in here. That's a very interesting discussion, and we all know that this could go on for a very long time. It will not be settled even if we spend an hour on it. So we'll have to go back to that and have a special webinar for that only, okay? But for the sake of time, we're gonna have to move forwards now. I'm gonna direct the attention now to Dr. Nihal Al-Shakhankiri and Dr. Mohammed Farid.
Thank you. Thank you. We are moving.
The case is a 6-month-old baby having unilateral congenital cataract in the left eye, as you see here. We did her cataract surgery at the age of 6 months. Concerning the IOL power, we didn't follow the Dahan guidelines, which stated that we have to go for undercorrection by 20% under the age of 2 years. And we did only undercorrection by 4 diopters. So she was left with 4 diopters hypermetropia in order not to have an isometropia, not more than 4 diopters. Immediately after surgery, we did fit her with the glasses with the 4 diopters hypermetropia, and we did start the amblyopia therapy. 6 months after surgery, she was compliant with the glasses and amblyopia therapy. After surgery, still maintaining straight eyes. And then 3 years after surgery, yes, she had a clear visual axis and still maintaining straight eyes, but she was left with a myopic shift of -8 diopters. And there is a non-compliance with the glasses, and she started complaining of intermittent exotropia. So the question is, how to treat a -8 diopters and myopic shift in a 3-year-old child after having unilateral pediatric cataract surgery? Would you go for glasses, contact lenses, corneal refractive surgery, or IOL exchange?
Going to launch a poll at this stage, and let's see.
The poll would be at the end of the presentation, Dr. Nihal.
Well, we can.
Yes, okay.
I think that's one of those polls that will not have a consensus.
And I have done my role.
Like
big diversity, yeah.
Okay. As we can see, these.
Yes, there's division in the opinions. Okay, Dr. Nihal, you can proceed.
Okay, so, well, actually, as for me, I cannot go for glasses because she's totally incompliant now with the glasses, and she's left with the fear that if she's not going to wear her glasses, she's going to go into amblyopia, and the intermittent exotropia going to be constant exotropia. She maintained a good vision along the past 3 years. So the glasses is not, I cannot choose it. Contact lens, it's not actually possible thing, at least in my patients, due to many factors. It's not only for the socioeconomic state. You have to change the contact lenses every now and then. It may be lost every now and then. We don't have the soft lenses or the contact lenses, which is possible to fit for infants and children. The weather, the hot, the humidity, the hygiene risk. So the contact lens actually it's not a possible choice for me. Concerning the corneal refractive surgery, it's too early to go for a corneal refractive surgery because she developed a myopic shift of -8 in 3 years old, when she's 3 years old. As you all know that 80% of eye growth occurs in the first 2 years of life, and 20% of the eye growth occurs at the age from 2 until adulthood. So she is liable to have, if we go for a corneal refractive surgery, even if the cornea permits to go for a corneal refractive surgery for a -8 diopters, she may develop another myopic shift in the late teens. Maybe it's not going to be of a -8 diopters. So I prefer to preserve the cornea and leave it virgin, maybe for a future corneal refractive surgery if needed in the future. So actually, I prefer to go for an IOL exchange. When you go for a straightforward cataract surgery and you choose the right IOL, you dilate the pupil like that, and it is possible with a Sinskey hook to rotate the IOL easily. There is no adhesions in the bag. To rotate it easily here into the anterior chamber, and then through a side port with a 23 gauge forceps, you hold the intraocular lens, and with the long Vanna scissors, you have to use the 11mm blade. You can cut the intraocular lens into 2 pieces, and then get out the first piece, rotate the second piece and get it out, and then you can implant the IOL, a multi-piece, unfolded and rotated in sulcus easily. Single piece hydrophobic IOL inside the capsular bag between the anterior and posterior rexes. At time of IOL exchange, you can easily dislodge it outside the capsular bag. There is no adhesions with these intraocular lens. When you choose the right intraocular lens, you get it inside the anterior chamber, and then you cut it into pieces easily, get it outside the bag. And in some cases, with single piece intraocular lens, you can reopen the capsular bag again and re-implant the multi-piece intraocular lens inside the capsular bag. You can see here that the haptics inside the capsular bag. And here, the child, years after IOL exchange, the IOL is located inside the capsular bag. Maybe the haptic is slightly compressed, but the IOL is central, and we have a clear visual exit. And each summering ring, we can aspirate it, and we can open the capsular bag and re-implant the IOL between the anterior and posterior rexes. As for me, as a take-home message, that the IOL exchange is not that difficult, and it can be one method of treatment of myopic shift after unilateral congenital cataract surgery. But in one condition, if you go for a good primary cataract surgery, anterior and posterior rexes, and you choose the right IOL, because not all intraocular lenses can be easily cut and there is no adhesion, so you have to choose the right intraocular lens and place it perfectly between the anterior and posterior rexes. If you do so in the future, you can do the IOL exchange and place it in the sulcus, and even you can perform optic capture inside the capsular bag, as I previously showed. And thank you.
Thank you, Dr. Nihal, for the nice case and nice presentation indeed. Of course, situation we are expecting some more questions and some more debates. The question now is for Dr. Barsa regarding surgery for unilateral cataracts in this young age. The child was about 6 months old. Do you prefer after removal of the cataract, do you prefer IOL implantation or using a contact lens?
Well, I have to first say we're obviously dealing with a master surgeon here, and I think more and more the tendency at 6 months of age is we can put in, IOL implants. And especially, I heard about the socioeconomic conditions about having a contact lens put in. They obviously get lost frequently, and it can be better to put an IOL. It may even reduce glaucoma incidence. There's a debate about that. So I thought that was fine. I have a question for Dr. Nihal, though. Given the myopic shift that occurred, so it was pretty dramatic in this case by age 3, could you have considered doing the IOL exchange a little bit later, say at age 5, because a silicone contact lens might still be tolerated until age 5, and maybe they're not too expensive, and further see how much myopic shift there would be or not, so that when you do the IOL exchange, you're doing it for the closest amount to an adult refractive correction. In other words, buy a little time before doing the IOL exchange with a silicone contact lens that's usually tolerated till age 5.
Well, actually, number one, the silicone lenses are not available in Egypt. And number two, the concept of contact lenses in children in Egypt is not actually a good idea. We have a very high risk. We used to use it in the past, and we had a very high risk of infections. So we don't use contact lenses in Egypt for cataract, after cataract surgery. So it's not an option actually in Egypt, although it's a beautiful option.
So what is the youngest age then? I mean, so you're putting it as a primary procedure in 2-month-olds?
Well, actually, concerning unilateral congenital cataract, the youngest age I go for IOL implantation is 6 months. I don't go less than 6 months because, of course, the curvature of the cornea changes massively. So we're going to have the myopic shift within few months and not actually few years. So I even at the age of 6 months. And I don't undercorrect massively to the 20% because I'm going to be left with a high hyperopia. I undercorrect from 4 to 6 diopters only in order to be able to fit it in spectacles after surgery.
So for the children who are younger than 6 months, how do you manage them optically then?
I go for cataract surgery and then I fit them with aphakic spectacles, half waking hours. I make the fellow eye with a ground glass, and the baby wears the glasses just for half waking hours until his age of 6 years, and then I go for secondary IOL implantation.
Okay, so it'll be the glasses. All right, thank you.
Okay, thank you, Dr. Nihal. Which formula do you use in your IOL implantation? Which formula regarding biometry?
Well, the formula which goes fine with me is the SRK.
SRK? 2, okay. Now there is a question for Dr. Orgay about methods of avoiding myopia, progressive myopia in unilateral cataract patients. Do we have a rule for atropine?
It's such a fantastic question. And then just like you I just want to first of all congratulate on the fantastic surgery that Dr. Nihal has performed. As always, it's eloquent, it's beautiful, and as she mentioned, and I agree with Dr. Parsa in the sense that I think in circumstances I would wait for that exchange, for that growth, because it tends to go. But again, it's so much person dependent and patient dependent and the situation dependent. There's no question in that. So the myopia role and why is the myopia happening is such a loaded question, and I don't know if we know the answers, and it's been looked at and continues to be looked at. The atropine is a fantastic thing that seems like it's just kind of everybody's trialing, and many other, including the PEDIATRIC studies, have been trying to look into that. The ATOM studies have been looking into it, but no, as far as I know, no prospective study has been kind of looked into this condition in particular. There are other conditions like would that work in ROP babies that actually we tend to see, or we with Stickler syndromes or neurodegenerative diseases, and obviously the underlying problem is a little bit different. So I think it could be IOL dependent, and depending on what's causing this, is this the peripheral blur effect that tends to be, and is that inducing something? Is it the overcorrection or the because when you look at actually, Dr. Archer actually looked into this along with Dr. Monte. That I haven't seen in my experience, and the IATS group has not either. But some investigators see that they actually go with imotropes, unlike the IATS group. And my formula, I still go along with the IATS numbers anyhow. And I think it's been shown again and again with the current technology, unless we know that atropine is working. So would I use it? I think I would. But I don't have the results for that at this point. But is there any way to predict this? People have looked into the other eye, the family's eyes, the genetic factors. I think it's hugely unpredictable. And it ranges from literally -10 to +10 of over and under correction, even much more than that. So with and this is coming from the best surgeons that you would all recognize their names from, and they kind of depict this again and again, with everything done at the way that you want them to do, and in prospective studies. So there's some unpredictability. I think it could be a healing portion too. It could be the IOL placement. And again, all these things are speculations. Back to your question, the right answer is I don't know. But does the atropine have a role? I think it may. So is there a harm to that? I don't know. And I would use it.
So you have any other plans of management for this case other than the IOL exchange?
So the IOL exchange is, I'm lucky in my facility, actually, we do give away contact lenses. So not many facilities can say that, because it is not a cheap thing. And we had one patient, and that's, I think, how this spurred up anyhow, that went through 9 contact lenses, and 2 of them, the baby ate it, and in 3 months. So what do you do? I mean, these are, in US, it's about $300, $350. It's not trivial at all. And unfortunately, insurance doesn't give, because the contact lens is contact lens from the insurance company standpoint. We're lucky that we have an endowment that we do actually give away contact lenses. So and I have an optometrist who's phenomenal in aphakic contact lenses, taking care of that for 20 years. So when you have a facility like that, it would actually go along with that. And they do actually provide better optical correction than the glasses, I think, especially when you have that kind of an anisometropia. Luckily, the kids actually don't really complain of the anisometropia as much as we think they do. How do we know? Because of other conditions that you see these huge anisometropias, and they still can have a decent stereo and actually have a decent vision if you can maintain that. So that's the good part. But actually, I have to say, I was fairly shy myself about going back to the eye and doing the surgeries on kids. And although it didn't sound that way in the nystagmus talk, I'm actually fairly conservative in many ways. And until recently, and we were discussing this again within a panel in APOS, and Ed Wilson, I heard from him, and I've heard a lot of things from him and learned from him too, that he was much more comfortable doing the IOL exchange. And then actually I started kind of being a little more cavalier about that. Now, I would still go along with what Dr. Parsa said, because I actually go along with, can they tolerate the contact lens? Can they tolerate the glasses? And wait until they grow as much as they can. Then if there's a compromise in the vision and the function, then that's the time that I go along with it. If you allow me, I'm going to show a couple of things on and other technologies that we use. Would that be okay? Can I share that?
Okay, we will share. Yes, we will take it from the at the end of the sharing.
Okay.
Okay.
But these are the things I would.
Question for Dr. Barsa about the role of corneal refractive surgery in such cases.
Well, I think I agree with everybody else that the child is much too young to consider that, because we expect further changes and maybe when they're an adult, it could be considered. But at this point, you don't have stability of the refractive findings. And so I would stay away from that. I think the issue of atropine, I agree with Dr. Orger, I don't see much to lose by trying it. We don't really know exactly how it works or might not work, but there isn't much to lose. And these kinds of situations makes it kind of exciting to try, for these rapidly progressing unilateral myopias. Why not? So I would also say that's something to consider but there's no experience really to guide us.
Okay. A question for Dr. Nihal regarding in case of recurrence of progressive myopia after IOL exchange.
Well, it is possible. It is possible to have another myopic shift, but it won't ever be that huge because already the growth occurred in the first 2 years of life. So we are expecting to have another myopic shift. Maybe she's gonna need this refractive surgery, but maybe in the teens or even in the 20s. So definitely.
You think of exchanging the IOL one time?
No, just one time. I cannot go for a second IOL exchange.
Yeah.
Just
okay. For Dr. Urge, any other options regarding implantation of other types of IOL, like artisan IOLs or piggyback IOLs?
You're absolutely right. So people have been looking into this, so you can actually do the piggyback, and actually some people knowing that the shift is going to happen, they go with the immobilization with the piggyback IOL. So when the shift happens, they take off the piggyback, which actually in many ways kind of, at least it's minimizing the surgery, because I think it's much more traumatizing. And we had a workshop. I mean, not that I don't know, and even in the best hands, still this is a surgery, and if less you complicate it, it's the best that you can do. The artisan lens is new to US. We are still in the trials to kind of make it happen for the FDA approval. There are, I think, 12 sites altogether, as far as I know, that actually is looking into the pediatric IOL, the artisan lenses. But it's much more widely used in all around the world. The problem with the artisan, which it does work actually fairly well. For high myopia, it does. But with an active kid and maybe prone for accidents and mishaps, that could be an issue. So dislodging is a thing to kind of know about. And I think if they dislodge, obviously just that could be affecting the cornea. But it does work. And there are many instances in obviously Netherlands. They've been doing this for 40 years, 4 decades, in different iterations, and they see that it actually works in their hands. And I don't have that amount of experience in my hands, but I have done artisan lenses for many aphakia, not for high myopia correction. But you're absolutely right. These are definitely options. Among them all, if I had the chance, and if I would do the surgery, I would do what Dr. Nihal did, and exchange the IOL. I would try to see if I can put it in the, do that is you need to know the anatomy. So coming back to that technology that we were going to talk about. And then if that allows me, then put it in the bag, which you can. If not, then a sulcus, but you still need to know the anatomy to really kind of choose the appropriate IOL for that.
And now back to the new modern technology that you mentioned about assessing the integrity of the capsular bag using a new 3D
yes.
UVM. So you can share it. You can share it with me.
Okay. I'm going to quickly do this, and there we go. I hope you can all see this. I'm going to make it. Can everybody see this? So for people who have not done or who has no idea what a UBM is an ultrasound biomicroscopy. It is an ultrasound, but it's a very high resolution. The typical ultrasound in the back of the eye would show around maybe the optic nerve, so that would be 10 to 12, maybe 20 megahertz. UBM is considered to be a UBM if it's more than 35 megahertz, up to 100. And here, for example, it works fantastically because and look through the tissue. So I actually use UBM fairly well, frequent. And then the idea came up, well, can you actually obtain many images? And in this case, we actually get about 1,000 images, and can we stack them to make it a collage of these images? And we've been working on this in the last 4.5 years, I would say. And there are a lot of technologies that you have to kind of make sure that the images are acquired in an easy way, but hopefully these are some of the results. This is the first cadaver eye that we've seen. It really kind of shows you, and can you see my cursor here? My the little
yes, yeah.
Look at this round tissue, and actually you can see this is actually real. This is cornea, and I'm going to show you a little more examples. I want you to see this little circular structure there. You can't see this really in individual images. That's actually scleral spur. So some of all apparently is showing a little bit more than what we can see in individual patterns. And Another example is maybe an iris cyst here. I'm just going to show this very quickly, just for the sake of time. And you can actually slice and dice these images in any way that you want. And the advantage, coming back to, I'm going to go through these slides a little bit more faster, is to kind of see the positioning of the IOL. Even if you have a secondary IOL, we always worry about where does the haptic lie. And to tell you the truth, there's no technology. I mean, OCT cannot penetrate the iris to show this is the back view, this is the front view. And when you're kind of slicing these informations, you know exactly where the haptics are. You know exactly where the IOL is lying. So if you have at least a UBM to really look at these images, and in the right, there's this is a image semi-automated acquisition in the sense that it actually detects the foreign body, so that you can actually kind of really turn on and see exactly what it is. Again, these technologies seems like it's been helping with us to really choosing. Scar tissues do happen. You need to know where the proliferation of the lens does happen. And if you can actually see them, avoid and make sure that you take appropriate actions. So what we do is we actually take these images and look at them, study them, and do the surgeries accordingly. And that has been helping. So I'm going to stop there. I'm going to stop the sharing.
Very interesting indeed. Thank you.
Okay.
Pramod, if you have any more questions for
Dr. Nihal, I have a couple of quick questions from the audience because we have to move on for the sake of time. The first question is it easier for you to get out a single piece IOL or a multi-piece one? And the second question is, the second IOL, when you come to implant it, do you implant it inside the bag? Can you actually reopen the bag after 3 or 4 years and put it in the bag, or do you put it in the sulcus?
Well, actually, both. You can get out the single piece and the multi-piece outside the capsular bag. As I told you, it depends on the primary surgery. If it is a straightforward surgery, and you use the right intraocular lens, because not all intraocular lens can get it outside. For example, if you have the hydrophilic inside the capsular bag, sometimes doctors use this IOL, there is fibrosis around the haptics, and it's very difficult to come out. And if you use a PMMA IOL, it's very difficult because you're going to have a large wound to get it outside, and there will be fibrosis, and sometimes it's extremely difficult to get it outside.
The question was about would you use a multi-piece IOL or a single piece? Are they both equally easy to get out of the bag?
Yes, but with the single piece, you have a sort of preservation of the capsular bag. It is possible to re-implant the IOL again in the capsular bag if you primarily use the single piece. But of course, it's not in all cases. In some cases, you can re-implant inside the bag. And if you don't implant inside the capsular bag, you can do easily sulcus IOL with optic capture technique. And actually, we did thousands of cases.
Thank you, Dr. Nihal. Now we're going to move to the third case today. Dr. Orge, you're up next with the case. If you would be kind enough to share your slides and start your presentation. Dr. Orge, can't hear you. You're muted, so can you please unmute the mic?
Can you hear me now?
Yes.
Oh, fantastic. Thank you. And actually amazing that the program reminded me that I was actually muted as well. So thank you. Not every surgery is EGP, and sometimes things do happen. I wanted to share things that I hope you never come across with, but sometimes certain things you come across with kind of stops your heart a little bit. And maybe pick your kind of brains in the sense and what to do when something happens. So she was a 54-year-old at that time, and with a history of a long-standing strabismus. Who she had a surgery about 30 years ago, actually multiple surgeries since then, but she had a consecutive exotropia, and we don't have any records on what was done, but the surgery appears to be, at least they've done a BMR by we could decipher. And in the examination, and I don't have the videos and the pictures, I apologize, but I think it's relatively irrelevant. I'm going to kind of come to the point anyhow. She did have a -2 adduction deficit in the left eye. So we plan to explore the left medial rectus, thinking that maybe this is a slips muscle, an elongated scar, something that is going on. And that's what we did. But when we started exploring the muscle, we just could not see any signs or extension of the left medial rectus. Maybe a few fibers and way distant, but not surprising with a -2 adduction deficit. Since we saw that, we said, well, let's kind of transpose. Now, there are a lot of ways to transpose the muscle, and I get it. Why not do just one muscle versus partial this, that? We felt in this case that the left inferior rectus and the left superior rectus full tendon transposition was the way to go. And so we first, the left inferior rectus was identified, hooked, cleared from the soft surrounding tissues. And while I was actually I did pass the first vicryl in the center, then I reached out to get a Q-tip. Then all I heard, and it's a fantastic surgeon, my fellow at that time was holding the muscle with the hooks, and I heard this oops. And again, she has, the fellow had amazing hands, and this, I don't know if it's anything to do with that or not, but the oops never sounds good. Then when I looked at the area, I couldn't see the eyeball. The area was covered in blood, and the hook that she was holding was free in the air, and the fellow had this devastating look in her eyes, and as if, what did I do, and what do we do now? So it kind of looked like this. This is the portion that I had passed the suture. Can you see my cursor there moving?
Yeah.
Fantastic. And this is the surgeon's view. That's the superior aspect. And these are locking forceps. So we're trying to kind of identify, well, we saw this piece, and we could see the suture kind of that was, we didn't even do the tie, the center. This is after we cleared the blood, trying to assess what's going on. And then we were trying to kind of find the other piece of the muscle. Now I have to say, and we're going to in the case, but I have to mention, if you're going to have a maybe pulled in two, maybe this is the best muscle to have a pulled in two syndrome. The reason is, as you all know, there is an attachment that the inferior rectus in a deep tissue with the retractors, as well as the oblique structures, the inferior oblique, all kind of connects deep down here. So in general, when this kind of a trauma does happen, it's actually unusual not to be able to find this portion of the muscle itself. The trick to that is, which I had accidentally learned on my own, then was confirmed by Dr. Baker many years after. I had seen another, thank God, I had seen another trauma patient who had split in two, then it was caused by the trauma. And I had accidentally had pushed the ball down, and that retropulsion of the eye allowed this piece of the muscle protruding up. And that was the trick that I can tell you, that we had actually kind of, as soon as I pushed the eye down, I saw this, and we caught it with the locking forceps in both ends. And what we did from there was just to kind of put these muscles together. So first of all, you need to identify, make sure you have the entire thing, and really assess if there is multiple pieces and what portion is broken. In this case, it was a relatively clear cut right into center. It kind of snapped, and that's exactly what happened. And then we actually, and there's a long debate that we can actually kind of talk about which sutures to use and all these things. I use the vicryl, and that's what I've used in the past, and I did not so far regret that either. But you can use a permanent merceline or nylon suture if you wanted to, Proline, but I use the vicryl. I used actually 3, almost like a mattress initially, then reinforcement in the center. I really want to make sure that this muscle was securely kind of tied to this. Well, then the question is, what do you do for this case? Now you not only don't have the medial rectus, and the inferior rectus is kind of compromised, and what to do for this? it must be a crazy day for me. I said, well, let's keep going. It seems like the muscle looks fine now. And that's what I did. So what we did is we actually secured the muscle and continued with exactly what we wanted to do. I don't do this typically. Normally, imagine this is where the medial rectus is supposed to be. And it would be around here to here. And I said, well, instead of putting it at the border where I think it is, why don't I meet them right in the center? And that's what you're seeing. So it looks bizarre. So this is the superior rectus. This is the, to almost meet with each other. I didn't put any other suture in between. And so that's what we did. And keeping our fingers crossed, we got extremely lucky in post-op day 4. Because of the inferior rectus probably was not acting as well, and you can see the bruising. All the extension of the inferior oblique, we talked about it, it just kind of goes through the retractors of the lid, and this is not uncommon to see. And in post-op day 7, she became ortho. Talking about nystagmus, her vision was 2100 prior to the surgery, again and again. And I don't know, we induced a kind of a tenotomy reattachment of some sort. Her vision came down to 20/60 within a month or two and prevailed that way since then. So we got extremely lucky in this case. I am a blessed person in many ways, apparently, but I want to share these things, not to show how lucky I am, but I am. But things do happen, and I remembered actually he has benefited from Gene Halveston quite a bit as well. I remembered, I always do remember him saying, better to do a good surgery for the wrong indication than a bad surgery for the right indication. But things do happen. So really make sure that every step that it's well calculated and it's done for the right reason and in a good fashion. And the expectation of the patient. So in the core discussion, so if there's any problem that is going to happen, you have to, a lot of things can go wrong. I didn't mention the pulled in too, because I didn't expect that to happen. But she was actually more calm than I thought she would be. But I never kept it to myself. I actually shared the entire thing with her, saying that this is exactly what happened. But the important thing is keep your calm. And bad things happen. You have to kind of figure out what to do at this point. It's so easy to kind of be flustered and start yelling at everybody and this and that. That doesn't help anyone. Communicate with the patient when complications occur and just kind of good luck. And I think luck is a big portion of this anyhow. So that's what I had in mind.
Olga, it's a very interesting case, and you kind of pushed your luck a little bit with this case because you know we have one very interesting comment from one of our audiences. Just closer up, it's a bad day, and that's what I've thought of doing. Like once you get the muscle lost, and then because actually a very it's a lot of courage to actually transpose the muscle after being split and finding it. But I would like to highlight something that you said that I didn't actually know. I never did it before. That when you have a pulled in two syndrome, what you said is you have to push the globe down in the orbit, deep in the orbit, and that's how you retrieve the lost segment.
It mainly works it particularly works in the inferior rectus. So it wouldn't work in the medial rectus, that I can tell you, because there's no connective tissue. And actually, Kenneth Wright says that, and I heard him saying this multiple times. It's kind of funny and sad in a way, because he said medial rectus is like me. He has no friends, and I doubt that's the case, because I know he's well loved in many ways. Medial rectus has not much connections to hold it together, and that's why it's much easier to lose that muscle. So if that happened to medial rectus, good luck, my friend. It's just very difficult to find it, if not impossible. But the other muscles, I have to say, they tend to kind of stay in that vicinity, at least the ones that I've heard. I think a few years back, David Granite and his medical student, I think, which not this surgery, I had another pulled into, that actually I had added to that case as well. It does happen, and it can happen in any muscle. It tends to happen more in the more fibrotic muscles. So thyroid is a good example, very tight muscles. And I think the instrumentation also is a key. And obviously, I mean, I have to say, I mean, this fellow is phenomenal, and the fellow is now in a very good institution leading the pediatric ophthalmology. They're amazing surgeons. So things can happen in very good hands. but it's realizing. I've seen a close one that actually was happening in a chronic progressive ophthalmoplegia patient. I kind of saw these fibers kind of ting, 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 kind of breaking up one at a time. I said, just kind of stop. So certain muscles are a little bit more prone apparently. And I have to say it has to be the tightness that at least that I've seen and heard.
The pulled-in-two syndrome in the survey published in the JPUS says that it happens to strabismus surgeons about once every 10 years. So it's not a kind of thing that you would develop an experience in by doing more and more. And I want to direct my question to Dr. El-Adawi. He's a very experienced strabismus surgeon, and any experienced strabismus surgeon must have come across one or two of those pulled-in-two syndrome. Dr. El-Adawi, can you please give us your experience about the pulled-in-two, what happened, how to avoid it?
Yes, I met this case in 2005 with a patient 60 years old with neglected 6 nerve palsy, and the eye is fixed in abducted position with positive force reduction test. So it is very difficult even to hook the media rectus. After I opened the conjunctiva, hooking the media rectus, the eye is fixed in abducted position, whereas the assistant pull the eye in order to facilitate to take the suture, I hear up, and the muscle is cut. So the main risk factors in such a case, most of cases occur in old people and in pathologic muscle, such as neglected palsy, previous ocular surgery, thyroid eye disease, chronic external ophthalmoplegia, etc., etc. How to avoid? You have to have a somewhat experienced assistant in order not to hold the muscle aggressively. Also, not to do much dissection of the tenon capsule in order to see the opening in the tenon through which you can retrieve the muscle. If it happens, you have to try to retrieve the muscle, but the medial rectus is very difficult sometimes to retrieve because it will retract backward. But in such a case, I can retrieve the muscle and resuture it again. Obviously,
can it happen in a child? Is it possible to see that in a child, or do you think it's very unlikely to see it in a child?
I think it is unlikely, and even in literature, it is unlikely. Most of cases of pulled-in-two syndrome occur in old age and in previously operated muscles, in diseased muscle. Okay, very rare to occur in child.
Dr. Parsa, come to the more difficult situations. What if you lose the muscle and you get it pulled in two and you cannot retrieve it? What would you do if it's a medial rectus or an inferior rectus? Like in the surgery, lost and you cannot get it back?
Well, first, I'll emphasize what Dr. Orga said. With the inferior rectus, because there's so many attachments to the inferior oblique, you usually can get it. For the medial rectus, that's where I would actually try to, and it's happened once, I would try to call a more experienced colleague into the operating room, swallow your pride, get them in there. And the key, as was mentioned, is to look for the tenon sleeve and not go across the globe looking for the muscle, but look for the tenon sleeve. I'll mention a little trick that one of my colleagues, Mustafa Sandri, mentioned in Iran, is he'll go into the sleeve with forceps and try to grab tissue that he may not see, but look at the if there's a vasovagal response on the anesthesia monitor, because if it's a rectus muscle you've got, you'll slow down the heart rate by pulling on it. So sometimes you may not be able to see the tissue your forceps has grabbed, but you can deduce that it's muscle. So that's a little trick. If all that fails, the horrible situation you're saying here, I would actually refer to another surgery, another day. I wouldn't go directly to a transposition procedure that day, but I would try to arrange with an oculoplastic surgeon, an orbital surgeon, to try and look again for it. And I've been lucky that way. So that's kind of the algorithm that I would follow is look for, lost muscle, then get a more experienced colleague, and then even schedule with an oculoorbital surgeon.
Okay.
If all that fails, you see what the adduction ability of the patient is. And in the case that we saw here where the medial rectus couldn't be found, obviously there was some medial rectus attached to soft tissues that was giving some adductive effect. It was -2, not -4. So in that case, a transposition procedure could work pretty well. But I would do that in a second operation.
So you would not even operate the other eye, because sometimes you have a surgical plan, and once you get a pulled in tooth syndrome, you abort your procedure, and you go in another day to try to retrieve it. You don't do the other eye, you don't do a resection, you don't do anything at that stage.
Yeah, no, I try to go to where the problem is. And
you try to take a stay suture to try to keep the eye adducted so that the muscle gets attached somewhere in the sclera towards the medial side. Because it's been suggested by a colleague once that if you take a stay suture, even sutures from the sclera, even to the skin, just to keep the eye adducted the first day or two, so that you get some kind of attachment and helps you in retrieving the muscle. Would you?
I haven't tried, but it theoretically it makes sense.
So the stay suture actually helps when you have a scar tissue forming. For example, if this was an endoscopic procedure done by an ENT specialist, that they munched through not only the sinus, but also the medial rectus, is a very different animal. And in those cases, you know that the inflammation is coming. It's just the mucosa of the sinuses and the bone fragments and many other things, exudations cause this. In those particular variations, or when you know that there was a fat violation or the fibrosis is going to happen, I think the stay suture is more indicated in those cases. As soon as you release the scar tissue and have some movement, you keep them in the opposite movement that they're going to scar. And I don't think it will be indicated in a lost or pulled into or any other muscle at this point.
Well, it's something that every one of us will come across one day, and I think you can never be prepared for that. And every case will have its own decision at that point. But congratulations, Dr. Orge. I mean, you had quite a nerve that day to manage it in such a way and had such a happy ending for your case. We have, for the sake of time, we're going to move on. But before we move on to the last case, Dr. Orge, would you like to share with us showing your the simulator and your online teaching system?
I'll be honored to, and so let me actually put it up. So for people who have not seen this through the Academy and the partnership with American Association of Pediatric Ophthalmology and STRABISMUS, so APOS and AEO got together with the funds from the Knights Templar Foundation. We had formed about now 6-7 years ago the Pediatric Ophthalmology Education Center. So if you don't remember anything that I tell you today or tonight, just remember the Pediatric Ophthalmology Education Center, because it is the biggest library. We have about close to 1.5, if not close to 2 million hits from 215 countries to this site. And one thing that we wanted to make sure that people learn and see, because I know that how much I struggled learning strabismus because it's so visual. You need to see patients again and again to really understand the concepts. We wanted to launch a simulator, and this is, I'm going to talk about and there are two types of strabismus simulators. There's a basic type and there's a complex type. At least I'll launch the first one. And the other one that you were seeing is also, we have the retinoscopy simulator. So these simulators are as if a patient is sitting in front of you. So you go, and if you Google the Pediatric Ophthalmology Education Center, or if you Google strabismus simulator, this will come up. And when you start it, there are two modes to this. There's an explore mode, and we're going to go into that. And that actually teaches you the concepts and how to use them. Now, when you're confident, you can test yourself. So I actually use this not only for education and my fellows and residents and medical students and technicians and orthoptists, but also the patients. They really don't understand, why are you doing surgery in both eyes, but or for when my left eye is deviating. So let's go through the explore mode. And there are certain things that we do. There are 4 tests. Can everybody still see it? Is the video running fine?
We do, yeah.
Follow, and great. And this fixation targets becomes more important in the complex strabismus. We'll get to that. The basic type, the basic strabismus simulator is a comitant strabismus simulator, meaning the deviation is always the same amount wherever you look. So the fixation target is less of relevant. You can actually turn that off. There is a prism that you can put in front of the eye. You can turn the prism in different directions and yeah, put a prism in it. I get it, but it's just to simulate and on how it kind of cancels the movement, and that was the way that we predicted it. And you can actually, there's an occluder that you can occlude either eye, and you can choose either the right eye or the left eye to be the dominant. So in this case, we're going to keep the right eye dominant, and we're going to give, and it goes exo. When you go to the negative, it goes to ezo, and then you can do these tests, the cover, uncover tests, or alternate cover testing, or prism cover testing. We'll turn this every eye. You still see there's deviation, but if you hit the prism to be just the right amount, then you know you see no deviation. Now you know that this person has a 30 prism diopters of esotropia. Not only it's written there, but you can see it too, because that's phoria as well. And so hidden strabismus, as students and fellows, it actually is a hidden. So when you do a cover-on-cover test, it may not reveal itself, but if you break the fusion for a while, in this case, the simulator waits 2 seconds. If you do that enough, then the phoria kicks in. And if you uncover, then the eye kind of recovers, or you can actually induce it by doing an alternate cover testing. So if you have a condition, which actually is so common that we see in our clinic, as you know, if you have tropia and phoria at the same time, you can actually measure the total amount by doing the alternate cover testing. And if you put a prism in front of it, it actually cancels each other, and then you know exactly what the sum of all is. But if you really wanted to know in real life, or even in the simulator, what the tropia is, so you know the sum, so tropia and the phoria was 45, and if you want to only depict the tropia itself to decipher what is tropia, what is phoria, there is a tool here which is called causing the simultaneous prism cover testing, and it only measures the tropia. So you cover simultaneously with the prism and the occluder, and it simulates that. And if you hit the right amount with the tropia, it would actually have no movement. So these are the 4 tests that you can actually do with this simulator. And then you can go to the test mode and test yourself. Every time you go in there, there are 3 new studies or patients in front of you that you don't know what's going on and you're tested on. In the complex strabismus, though, you will see A and V patterns. You will see Brown syndrome, DVD, DHD. We're working on many others now. We're looking into these incomitant strabismus. Hopefully soon we're working on maybe a virtual platform of a clinic, so that you maybe go into a clinic that there are 10 patients in different rooms, and you can actually examine them, maybe make diagnose not only that, choose what surgery to do, give glasses, and see what happens. So thank you for allowing me to share this, Amr, and I'm just going to stop there.
We're very thankful for showing us this, and I know you worked a lot in developing this simulator. And for any of you who haven't tried it, it's free online. Anyone can go on and try it. I use it in teaching my students. I show it to my patients sometimes, to my colleagues. It's very interesting to play around with it. Please, if you haven't tried it, please go ahead and try it. And now we move on to the last case for today. Not the least, actually, the last and the most interesting of them. Dr. Mohammed Farid will take over, and Dr. Ibrahim Al-Adawi will present the case.
Thank you, Dr. Amr. We will move to Dr. Ibrahim Al-Adawi, as he's got an interesting case about unusual presentation and management of a case of superior oblique palsy. You can go, Dr. Ibrahim.
Please share.
Okay.
This child presented in February 2013 with head tilt to the right. By examination of the child, unfortunately, he's a troublemaker and I cannot take a good photo at this time. I diagnosed the case of left superior oblique palsy. And I mentioned to the parent that he will need surgery in the left eye, and sometimes he may develop the same pathology in the right eye after doing the surgery. Okay. This is immediately after surgery, I did a left inferior oblique myectomy, and this is the first post-operative photos. Next. In March 2013, immediately after 1 month, the patient developed head tilt to the left. After 2 months, the full-blown picture of bilateral masked superior oblique palsy with right inferior oblique overaction with head tilted to the left, and we prepare for surgery. I did right inferior oblique myectomy. And this, unfortunately, the first post-operative photo, I noticed the head is tilted again to the right with a small left hypertropia again. Next. The patient to travel abroad with his family and return after 1.5 years with full-blown picture of another left superior oblique palsy with left inferior oblique overaction, which is already myectomized. And usually after cutting the segment of the inferior oblique, I push the proximal end of the inferior oblique into the tenon capsule and close the opening with Whitfield cautery in order not to reattach again to a wrong place in the sclera. This is for the first time to meet such case after doing the other eye, the pathology or the hypertropia recur again in the first eye. I prepare for another surgery. I explore again the inferior oblique and I find everything's okay. So I did left superior oblique tucking. But actually I did very mild tucking, about 4 to 5 millimeter, because I was afraid the first time to do inferior oblique and myectomy together with superior oblique tucking. Next.
This is the poll.
Yes.
Audience. And the question was about when do you do superior oblique tucking as a first procedure in superior oblique palsy? You can share your answer.
I think it's going to be one of those where it's going to be very divisive. You're going to have a lot of different answers. And that's I consider a successful poll when you have like no agreement on something.
Yes, Dr. Amr. I cannot show the results from my side because I am sharing, Dr. Amr.
I would show.
Okay.
Everyone sees the result now, I think.
So 47% of the attendants choose not to do superior oblique tuck as the first procedure in superior oblique palsy. Okay. Okay, Dr. Ibrahim, we will continue.
Okay. Okay. Usually before the first surgery, I did the force abduction test, and usually I don't start superior oblique tucking except in very lax superior oblique tendon. But in this case, with oblique traction test, I feel well the superior oblique tendon. So although there is some laxity, but not too lax. This is in 2015. Again, I revised the superior oblique tuck and make another superior oblique tucking 8 millimeter. And this is the post-operative photos in September 2015. Next. After 3 weeks. Next. After 3 months, and he's still okay until now. This is the first time to see this complication. Why the symptoms or the signs of superior palsy reappear again in the previous eye, although after complete inferior oblique myectomy. Are any one of our dearest colleagues see such a case?
Yes. We will ask them, Dr. Ibrahim.
Thank you.
Thank you, Dr. Ibrahim, for the nice case indeed. And we will move to Dr. Barsa to ask him about how to predict the masked bilateral superior oblique palsy preoperatively. There is any way to predict the presence of masked bilateralism?
Well, yes. I mean, one has to really keep it in mind. Jampolsky says, presume that all unilateral superior oblique palsies are bilateral until proven otherwise. And one has to, you know, it's difficult sometimes with a child who's not very cooperative, as in this case here. It was hard to get pictures, but, you know, one obviously looks at the adduction, the hypertropia and adduction of each eye. What I find particularly useful is to look at the ocular fundus torsion.
Yes.
And that is, I think, the biggest advance that we've had since, you know, von Norden introduced that in terms of unmasking these otherwise masked bilateral superior oblique palsies. There have been other rules when you see a large torsional component over 10 degrees that it's probably bilateral. And there's a number of, you know, just things that one tries to do during an exam. As I said, not always easy with children, but I think looking at the fundus torsion is the best help. Now, sometimes when the normal position of the fovea, when you look at the fundus and with respect to the optic nerve, is in the bottom third of the nerve, we say. And what if someone initially had their fovea at the, you know, higher up, and then now they're palsied and they're still within the range of what we consider normal? We can be fooled in those cases. It looks on fundus torsion to be within normal range, but it's actually excyclorotated from its previous surgery. There, what sometimes helps is to look at the vascular arcades. The vascular arcades are more or less symmetrical and horizontal, slightly excyclorotated. But when you move away, not just looking at the fovea disc relationship, which can be hard in children, you know, they're not safe. But you can see the vascular arcade if it's incyclorotated or excyclorotated more easily. It doesn't give you a precise quantitative measure, but a very good qualitative assessment very quickly in a moving child, whether the eye is incyclorotated or excyclorotated. Then you can see if it's bilateral or unilateral. What
about the time gap? What about the time gap for development of bilateralism? Do you see it shortly after the first surgery, or it takes some time?
It can be pretty quickly afterwards.
Quickly.
You know? Yeah.
And did you manage them quickly, or you wait some time for the second surgery?
It depends. But, you know, if they're fusing, you can, you know, wait. You certainly would wait until the first surgery has healed.
Okay.
There's no immediate rush. One thing I'll add, when one does an inferior oblique procedure, weakening procedure, and sometimes I see with some of the residents, they don't get that the exaggerated force ductions that David Guyton introduced in the field to see how tight the inferior oblique muscle is at the time of surgery. One can do that in both eyes too. Before you start operating, is check, do you feel a tight inferior oblique or not? And also check at the other eye. You know, that could give you another tip if you've missed a bilateral superior oblique muscle. So you assess how tight it is in the other eye, even though you didn't think that there's something there. And after, in the first, let's say you don't see it in the other eye, but after you disinsert the inferior oblique muscle from the first eye, repeat the forced ductions, the exaggerated force, to see if you're sure you got all the fibers. Because the inferior oblique muscle, it's very easy, even under direct visualization, even with a microscope, to miss some of the fibers.
Yes.
In the hook. I mean, some of them even have bifid insertions. And if I don't do a second exaggerated force ductions after disinserting, to be sure that I've got all the inferior oblique muscle, and you see that you have an undercorrection after your first surgery, you can assume that what happened is you didn't get all the fibers in the first surgery. And I think that's something that has to be emphasized, that we should always remember.
What about, in your opinion, what about the second surgery? Is it the same protocol of the first surgery, or you will tailor the second surgery according to the amount of hypertropia? Do you treat muscle bilateral symmetrically, or?
Yeah, I pretty much do. Yeah, and sometimes if I see, now I'm very shy about doing superior oblique tucks. So what I might do before that is actually go and do another myectomy of the inferior.
Yes.
You know.
Okay.
So that's the approach.
Thank you.
I have a question, if you allow me, Dr. Mohammed, just to enrich the discussion at this point. Some of you might have heard Dr. Plager saying, if you're going for a unilateral superior oblique palsy, and in the surgery you find a lax superior oblique tendon in both eyes, you would expect this patient to be a masked bilateral. Do you agree with this or not? And the questions, Dr. Parson, Dr. Orge, and Dr. Radawi. And if yes, would you do the inferior oblique in the other eye in the same setting? I mean, in the surgery, do you do force reduction test on the other eye, on the superior oblique of the other eye, in order to predict if this is masked bilateral or not?
Yes, I do. I do the traction test, but actually to change the scenario of surgery, the scenario of management based on the traction test on the other eye, intraoperatively, for me, I don't believe in this. I want to change my plan regarding the degree of laxity of superior oblique tendon. Though I will keep it in mind to check post-operatively if the signs of bilateralism develop.
Okay, so you do bilateral force reduction test on
yes, I do bilateral to check for the laxity of the superior oblique tendon. Okay. But by the way, I don't do tuck based on this laxity of the superior oblique tendon.
Okay, Dr. Orge, what would you do?
Superior oblique tendon, for me, it guides me about the amount of tucking. To the amount of tucking, not to the decision of tucking. I base my decision of tucking based on the preoperative examination about the degree of hypertropia in different gaze positions. If I found the hypertropia more in the direction of the action of the superior oblique muscle, I will think of superior oblique tucking.
I agree. Yeah.
I don't know if the other panelists agree with me.
So we want to hear the opinion of everyone almost about this bilaterality, predicting the bilateral, because it's very frustrating when you do one eye and like a month later you see the patient with the other eye. Parents are not happy usually with that.
No, they're not. Actually, I want to kind of add one more trick maybe to kind of decipher the bilaterality, and I agree with every comment that was made already. Sometimes though, one other trick is when you kind of tilt the head to the other side. So let's see if I have a left superior oblique and the right tilt and all the good, now if the left hyper becomes the right hyper, then you know that there's something more hidden there. So that's another tip to kind of think about. And all these things, I mean, God knows, in a 1-year-old, 2-year-old, good luck doing that. But all these things do add up. Now, but coming back to the question on what to do, I 100% agree that I think that the force duction, exaggerated force duction, actually guides me on what to do. My first line of defense is the inferior oblique surgery in these cases, because it just is such a regulating type of a surgery.
Adjusting,
it really is kind of adjusting. That's actually, thank you. That's was the word that I was kind of looking for. So even if you have a little hyper versus a significant hyper, in particularly myectomy in my hand works well.
Yeah.
Farouk, you're a bit breaking up on the sound, so Farouk, we cannot hear you, so we will.
What I'll just add to
And
the
again, if for the audience, maybe go with this. Can you hear me now?
yes.
Yes, we can hear.
Okay. So just to kind of as a reminder, we talked about Dr. Art Jampolsky, and this is, I think, from him, that the oblique and inferior oblique can come in so many different variations. I mean, look at how many different things that can happen to the muscle.
There's some problem with the voice of Dr. Farouk.
Oh, don't hear, Doctor.
Farouk, I'm afraid we cannot hear you, Farouk. So, Dr. Orge, we cannot hear you. So can move. We didn't hear the opinion of Dr. Parsa about this.
I'll just say, this picture says it all, you know, how easy it is to miss fibers when you think you have the entire muscle in your hook, because there are variations on the insertion. What I would say, add to what was just discussed about the inferior oblique muscle as being the first muscle to attack. Not only is it self-adjusting, it's so forgiving. I have never seen a case of overcorrection from operating on the inferior oblique muscle. You will never get a hypotropia. If you do, from doing a denervation, extirpation of an inferior oblique muscle, you'll get it will not last. It's really hard, if not impossible, to get an overcorrection from weakening the inferior oblique muscle. But with the superior oblique muscle, you can get all sorts of problems.
Yes.
Hey, Dr. Barsa, what about, in your opinion, the causes of recurrent over elevation in adduction, as we have noticed in this case?
But yes, well,
what do you think of the other possible causes apart from missing inferior oblique fibers?
I think it's the number one cause. That's by large the number one cause. And other times, even when you have totally disinserted it, you've done the exaggerated force ductions, you know you disinserted it, it will reattach. It always does reattach. Even when you've done a myectomy, I noticed Dr. Green was talking about cauterizing the opening in Tenon's capsule. I've thought of suturing them, but I've heard from my mentors and others, it doesn't help. It will still reattach to the globe somewhere eventually. So it seems that we ought to be able to prevent it, but it does. And there's enough soft tissue attachments that it still always has some effect, unless you do what Alexander Duane did in 1906. He would disinsert the inferior oblique from its origin on the bone. So if you do that, truly do an extirpation, then you're safe. But you get terrible bruises, and I haven't heard of anybody doing it since Duane.
So in such a situation, Dr. Parson, such a situation of recurrent over-adduction, what's your target surgery? Will target the inferior oblique to re-weaken it again? Or do you think, as Dr. Ibrahim did, to go to superior oblique to strengthen it?
I try, as I said, I can't, it's been maybe a decade since I've gone to the strengthening superior oblique. I try to avoid it at all costs. I'll do everything.
Why, Dr. Barsa?
Well, because if it's, in this case, he only had to do a small tuck, which is all right, and if you only need to do a small tuck, I might think I'll do something else. If you have to do a large tuck, you're going to get a Brown syndrome. And even though it gets a little better with time, I don't find it satisfactory, absolutely necessary to go that route.
What if happened? Acquired Brown.
I'll mention one more thing that sometimes isn't emphasized enough. If you have a very lax superior oblique tendon, that's what happens oftentimes with a denervated superior oblique muscle, one where the trochlear nerve has been interrupted. And with a denervated muscle, it becomes lax, like Craig Hoyt says, a wet noodle. And if you do a tuck, the result is only going to be temporary. Over time, the tendon is going to be lax again, because any denervated muscle, it becomes lax. So it's only in cases where there's some partial innervation left that it might work. So in the cases where you would think, you know, where the tendon is extremely lax, the tuck isn't going to work. It's not going to work long term. And many
in case of acquired Brown,
acquired sixth nerve.
if it happens, what is the possible ways of management?
Not many good ones.
Tuck before? Did you release the tuck before?
As I said,
is it releasable? Is it releasable in your opinion?
Dr. Mohammed, it is releasable. You can actually reverse it. Can you hear me okay? It seems like
okay, that's fine.
You can use it.
And Doctor, I would really urge you to maybe look into Dr. Saunders' paper that actually really describes eloquently how to adjust it. I can tell you Brown's is so easy, and actually where I did my training, Dr. Helveston had this series of Brown syndrome, so that whole Indiana was, I think, tainted with that, and a lot of people kind of.
We're talking about a surgical Brown versus the true Brown. These are two different.
I got it. So that when you tuck it though, so can you undo it? Yes, you can. So does it work all the time? No, it doesn't. It depends on how you've done the surgery. Just like when we were looking at Dr. Nihal's case, the first surgery has to be pristine, and you need to know exactly what you're doing. And Dr. Saunders actually invented a little device, Rick Saunders, and that actually kind of tells you how much to tuck. So it has a spring mechanism that actually kind of really calibrates, and how you do a forced suction before and after guides you if you've done it too much or not. And actually, Dr. Archer from Michigan in particular, they do superior oblique tucks probably more than anybody. I just wouldn't do it that much anyhow, but that's their to-go muscle. And I think they use the same method, and that predictability has been helpful is all I'm saying. So I am not, my first go-to muscle is not superior oblique either, but I do touch it fairly frequently for different reasons. I prefer to go to the inferior oblique, but if you do a tuck, do it in that fashion. I think that would be very useful.
I'll add one to my French because I have to. In France, the superior oblique muscle is the first go-to muscle. And I was astonished when I first saw them. And then I watched them operate, and I asked, you know, they're presenting all these wonderful results. And I said, well, don't you get a Brown syndrome afterwards? And the answer is, of course, but who cares about looking up gaze?
It's a very strange way to look at things. I mean, we can actually tell, yeah, we can know from the poll now that we don't have a lot of attendees from France. So a lot of people didn't decide to do superior tucking first.
Okay. Last comment to all the panelists regarding the technique, the preferred technique of re-weakening of inferior oblique in just one bullet. Dr. Ibrahim, if you are going to re-weaken the inferior oblique, what's your preferred method?
According to the original weakening procedure, if I had inferior oblique recession, I can make inferior oblique anteriorization, inferior oblique myectomy, nasal myectomy. But I want to comment the recurrence of over elevation and adduction, or the recurrence of inferior oblique overaction in the left eye. If I think if there is missing fibers in the inferior oblique, the head tilt will not be corrected, and the superior oblique palsy will not appear in the other eye. So it is recurrence, not residual. If there is residual inferior oblique overaction, if you missed some fibers from the inferior oblique, the condition will be still as such, not to be corrected, and the other eye developed superior oblique palsy.
Dr. Barsa? The preferred method of re-weakening.
Probably true. And I wasn't trying to say
the preferred method of re-weakening of inferior oblique.
Yeah, but one could do a re-weakening if you know.
In your practice.
Yes, and you can do denervation extirpation to try and get even greater result. It's not, you don't always find the neurovascular bundle. I sometimes have trouble finding it. David Guyton gave me a tip. He says, if you can't feel the neurovascular bundle that you want to cut to get even to release the muscle to do a bigger myectomy, you can go blindly in the muscle a third of the way in from the edge using cautery, so that if you cut it with cautery, so you're also cauterizing the blood vessel, so you don't get, and so you can blindly try that way. That's a tip he recently gave me, because I said, you know, sometimes I simply can't find that nerve. because it's too deeply buried in the muscle. So blind cautery can help, and that way you can do a bit more greater myectomy.
Yes. And finally, with Dr. Farouk.
Dr. Jorge? That seems he has a connection problem.
As well as connection.
We hit
Okay,
our
Dr.
limit
Amr,
on time. We had to hit our limit on time, so we'll have to conclude. Actually, this webinar turned out to be much more interesting than what I thought it would be. We had a very distinguished assortment of panelists here that enriched the discussion, and we're sure these discussions can go on for hours and hours, and we can never actually, that's the interesting about strabismus and pediatric ophthalmology. Not everyone does it the same way. Everyone does it in their own different way, and somehow it works, although we do it different ways. I really enjoyed the discussion myself. I'm sure everyone did. We wish we had more time. For the audience, this is going to be our last event in Ramadan, and we have the next week off, but expect more events. It's going to be always every Tuesday, but next week is off, as we said, and it's going to be different. We have more interesting panels. We have new things, exciting. We're gonna have to publish that soon. I should say thank you for the audience for staying that late. Thank you for the panelists, every single one of you, for enriching the discussion in that way, and we hope to see you again. Thank you.
Thank you, Dr. Amr. Thank you.
Very much. Thank you.
Bye-bye.
Bye-bye.